Hello everyone, in this video we're going to be discussing distributive shock. The most common cause of distributive shock is going to be septic shock. The other causes are going to include neurogenic shock and anaphylactic shock. Now the primary problem is going to be due to widespread vasodilation that is going to occur. This vasodilation is going to decrease systemic vascular resistance, as we see over here. Now, blood is going to then pool within the venules and it's not going to return to the heart. As a result, central venous pressure and pulmonary capillary wedge pressure are also going to decrease. Now, because of the vasodilation and hypotension, sympathetic drive is going to increase to correct for these. As a result, we're going to experience an increase in heart rate and myocardial contractility. This is going to increase cardiac index, which refers to cardiac output per body surface area. Now, mixed venous oxygen saturation is also going to increase, and this is due to the fact that we have high blood flow rates. With high blood flow rates, our tissues are not going to extract oxygen as they're supposed to. As a result, mixed venous oxygen saturation is going to increase. Now let's clear this screen and let's talk about what happens to the cardiac index and mixed venous oxygen saturation with neurogenic shock. With neurogenic shock, we're not going to experience the increase in sympathetic drive that we experience in septic and anaphylactic shock. Because we don't experience this increase in sympathetic drive, we're not going to experience this increase in cardiac index and increase in sympathetic venous oxygen saturation. So that is what is important to differentiate with neurogenic shock. With neurogenic shock, we actually have a decrease in cardiac index and mixed venous oxygen saturation because we do not experience an increase in sympathetic drive.